All right, welcome back. I'm on my comfy perch here, and so I'm ready to go with these live cases. And this is going to be all about live cases, interaction with the panels. We've got two great sites, both Rotterdam and Mount Sinai. But before we go to Rotterdam, let's start off with a poll. First, the poll is: in the treatment of calcified coronary artery disease, orbital and/or rotational atherectomy is A, a must-have, B, a nice-to-have, or C, not needed or not worth the risk. So why don't you all try to answer that, give you a moment to respond. And I see we're joined by both Nicolas and Joost from Erasmus with an atherectomy case. So please tell us more about this calcified case, what your thoughts are. I'm really looking forward to seeing it and interacting with you both.
Hi, Ajay. Good to hear and see you. Welcome back to the Cath Lab here in Erasmus. As always, with Joost here. Joost, our expert of imaging, complex PCI, and coronary physiology. There is also Stefan Surenska and Martin in the room to help us get us through this case. So Joost, we're going to demonstrate a patient with extensive calcific coronary artery disease.
Yes.
Why don't we start with the introduction of the patient? So the slides. The patient is a 79-year-old male, known with hypertension, and recently received an S3 Ultra TAVI for severe aortic stenosis. The patient is also in a trial where we did the TAVI PCI trial, where the patients are randomized to PCI before or after the TAVI procedure, and this patient was randomized to the PCI after. That's why he's here now. And preserved kidney function. Next slide. Here you can appreciate the echo, so normal LV function status after the TAVR, no PVL, no gradient. Next. And this is the meat of today. So the right coronary has some mild luminal irregularities. The circumflex, there is some disease in the distal segment, but it's a small vessel, small caliber vessel. And then the LAD is diffusely diseased, almost starting at its ostium. And I think Joost did the diagnostic study and also did some additional analysis. So maybe the next slide. This is a cranial, an areocranial view of the LAD, where you can appreciate several spots of severe stenosis in the proximal, mid, and distal segments of the vessel. Next slide. And then Joost.
Yeah, so this is a typical case in which you see some angiographic calcifications, but it's typically very difficult to really adjudicate the true severity of the calcium. So while looking for an appropriate case for today, I did during the TAVI, I did an OCT of the LAD, and this is what it showed. I'm just going to show you two images for today. So this is the distal part. So you see just after the band, let's say in segment 7, you see this subtotal lesion, and this is what the OCT at that point shows you, which is a very eccentric, let's say 150-degree calcified nodule, non-eruptive on the left side. And if you go next, you can appreciate the proximal LAD, which clearly is much more severely calcified, 180 degrees with very thick calcium. In this case, 1.3 millimeter in thickness over 180 degrees in a lumen area of 1.7.
Yeah.
So next, so we decided this could be an appropriate case. But what we did is we went back to the CT scan and we loaded that into our Pulse Medical CT FFR software, which already could have told us, so this is a photon counting CT with a non-dedicated coronary scan protocol, but yet you can appreciate the truly significant calcification from the mid-LAD towards the ostial part of the LAD. Plus, and that's what the mouse cursor is showing you now, the physiological gradient based on the CT, giving us a FFR CT of 0.73 with, very importantly, a very gradual or very focal pressure drop from the left main towards the proximal LAD. So that is quite interesting, because this information actually we could have scrutinized upfront irrespective of the OCT. So this tells you really a lot with a scan that you make anyway for these patients. Next. So we obviously also looked at the circumflex, and that basically showed us the same thing, spotty calcifications here and there. The ostium looked okay, but yet there is an eccentric calcification at the ostium. But also important, a very small caliber vessel with diameters of about 1.5 to 2 based on this CT scan. So with that, we actually staged the PCI towards today. So next. And this is basically our plan. So patient is under local anesthesia. We opted for the right radial. Now we have a left radial because we lost the right, I think, after the last 2 procedures. EBU 406 French. The idea would be to use orbital atherectomy and OCT for imaging. And this patient is on aspirin and clopidogrel.
Yeah, and so why orbital atherectomy? Because of the excessive length of calcific disease, I assume.
Yeah.
And and we're also. So do we discuss the hybrid approach?
Yeah, absolutely. So the idea of today would be to use the orbital atherectomy, but also to use the imaging to decide on whether we need stents or whether maybe, like in this small circumflex, a DCB could be an appropriate strategy to proceed with.
So a synthesis of the previous 2 sessions at TIO.
Yeah.
So the hybrid strategy also to avoid caging of the entire vessel, of the entire circumflex and the entire LED. So I think from that point of view, I felt quite comfortable in a hybrid procedure. So a lot of information here. Maybe Ajay, what are your thoughts when you're looking at these angios?
Yeah, look, I think this is a phenomenal case because a lot of illustrative points, and we'll tie together both prior sessions for sure. And love to hear the panel's comments quickly too. But one thing about this is that when you look at that, there's a segment that looks like it might be intramyocardial. It looked by the angio, at least you show that there may even be some bridging there. And then for any atherectomy case, we totally agree with you that the length issue is one that really favors atherectomy-based approaches, because even if you want to use IVL, it's going to take a lot of balloon inflation and things like that. The one area that you have to be really cognizant, though, of is that bend down, up, and down. And so I think having that CT, wow, that was really illustrative to show us that perhaps we don't have to go way distal, which actually would improve the safety profile of atherectomy for this type of case. So maybe Azeem, we'll start with you. Do you agree with what they're proposing in terms of how to do this case? And we'll talk about the DCB part a little bit later, but at least upfront prep this way based upon the CT and the OCT.
Yeah, a great use of the CT, by the way, the TAVR CT. I think we forget we have that information, so it's great you can maximize using that information. I was impressed by the thickness of the calcium at that point, and I think atherectomy makes me feel comfortable doing atherectomy, particularly orbital, when it's so thick and the vessel is maybe at that area not as tight. I think you could, there are other options. You could, if someone said, one of my faculty said to me, could I use a shockwave here? I think that's possible too, but like Ajay said, there'll be multiple inflations all the way back. So I like that approach.
And by the way, we can keep talking, but if you need to start working, go ahead, feel free to do that, or tell us what you're going to do, and then we can keep talking while you're doing it.
Yeah, so in the interest of time, I think we appreciated the fact that perhaps we would not be able to share everything live. So we already did some work, so maybe Martin can show you what we did. So we wired basically the LED in the circumflex. We did some ballooning in the circumflex with a 2.0 non-compliant balloon, 2.015 twice. With that, we had actually a good angiographic result, and we opted for a 225/40 Essential Pro paclitaxel-coated balloon, and then did an OCT. And perhaps that's nice, because there's obviously always a lot of debate as to whether this is which balloon result is, so to speak, good enough and warrants the lack of a stent. But what this OCT shows you is that this vessel is small and diffusely diseased, exactly in line with what the CT showed us. Here you see the lumen area is about 1, and that's even distal to where we inflated the balloon. Here we go more proximal, a lot of eccentric plaque, fibrofatty plaque, calcifications here, enormous calcifications actually here at 9 o'clock. Here it's good.
Can you switch to the OCT for us? We're just seeing the angio. Perfect.
you should see the OCT now.
Can you see it?
We see it now.
You see now. Oh, good, very good. So distally, small diseased calcium here at 8 o'clock, and then proximal here. This is the area where you see the dissections caused by the ballooning. See some luminal gain here, 3O now. Very diseased vessel. You see very minor intimal thrombi, so just some luminal attached white thrombus here and there. Here you see the calcifications again from 9 o'clock to 6 o'clock. Diffusely diseased vessel. So
But nothing to worry about in terms of the dissections.
in terms of the intimal damage, I would definitely not be worried at all. And what is also very important here, and that was the ostium of the circumflex. Maybe Martin can show you again. This to me is perhaps the most important information of the OCT, lumen area 6-1 in the bifurcation with the ostium of the circ. So obviously you could have opted to put so here we are at 48 millimeter 225 stent, which would be too big for the distal reference. But I think this is a beautiful case to warrant the use of a DCB. But that's our opinion. We would love to hear your thoughts, obviously.
Well, I think one advantage of doing it this way also is that while you're working on the LAD, you get to watch the circumflex. And so if you're worried about dissections or things like that, you at least can observe what happens during that time. Whenever I have a question about DCB, I always ask Margaret because she has so much more experience, certainly, than I do, having worked abroad in Europe. And also she's leading a trial. So Margaret, what do you think about this strategy? I think in the US, operators would say, this is crazy. You got to put a stent in here. But is this the future? What do you think about it?
Yeah, perfect.
Yeah, I think certainly for the circ here, where you've got small vessel and less than 275 and a long lesion, this would be, I suppose, a very nice de novo trial patient. And a lot of the larger RCTs that are underway or about to start, this patient would be included in one of the US de novo trials that we're starting for that reason. Yeah. So I think that is a great strategy. It's kind of interesting in this case because it's a really nice example of how the imaging, I mean, if you look at that LED on the run we see just now, the proximate stuff, over the diagonal doesn't angiographically look critical, but then actually I think the MLA on the imaging was really small. So it's kind of interesting that, isn't it? And you can very clearly see there's a very thick eccentric plate of calcium and that proximal lesion in the LED. And then, as you said, Ajay, I am suspicious that there could be a little bit of bridging and hinging in the mid-LED before that bend in the vessel. When you watch the movement of the artery, we know from a lot of the work that Kiko's done that the prevalence of bridging in that segment is much higher than we've previously thought. Yeah. So I'd just be a little bit aware of that and study the imaging quite closely. So I think it's a really nice case for hybrid. In terms of atherectomy, I don't know. We've just talked about eclipse. I don't know if I would have gone straight to atherectomy in this case in my practice. I might have taken a different approach, but we all know there's many ways to do these cases, and it's a judgment call.
So why don't you show us what you've done? And I will say from a safety standpoint with atherectomy, if you're going to use atherectomy, I would caution people, you need to learn from experience that this is not the type of case where you want to take the atherectomy device beyond that bridging-ish type of segment around that bend and around. I really think that from a risk-benefit standpoint, the risk is a lot higher than the benefit of going down there. And you also saw what the CT showed. So you have to be thoughtful when you use atherectomy and optimize the efficacy and minimize the risk. Go ahead, Joost and Nicolas, show us what you did.
Yeah, so
what you're about to do.
Go with the atherectomy. We had a little bit of a debate as to whether we should take the proximal nodule or not. But then what we did actually is that we went in with the glide assist very gently and did a very short run distally. And then went back and did a back and forth in the proximal segment, low speed. So in the proximal segment where we knew that the thickest calcium was. Next. So this is the proximal run in which you can appreciate the orbit going through the proximal calcifications. Next. And then we did an OCT run next.
So we had the audible feedback that we were interacting with the calcium, both distally and more proximally. And so then the idea was to do an OCT, and we did that OCT right before we went live. So maybe Joost, let's go into
Yeah, so here we start very distally, and you can see a couple of things here. So here really you see the thick media, but also this eccentric chunk of calcium. Very difficult to interpret. This is after, by the way, so this is directly after the orbital. So a tight lesion, which I find really difficult to interpret what we did and what we should do, but that's a good thing to discuss. Here you can clearly see the bridging. Yeah. So you can see also in the longitudinal view, so if Martin, you go from 60 to, let's say, 45, you clearly can see the whole vessel caliber decreasing. So here it's about 2.0, and then it goes down to 1.27 here. But there's virtually no plaque. So there's some plaque, but definitely nothing severe. So what is also interesting, Ajay and Margaret, so this is where we went with the glide assist through the vessel, and you see basically no damage in the distal segment. The only damage comes here at about 40 millimeter, where we clearly generated some intimal tears with the orbit. But if you really look at the very thick chunks of calcium, I'm not so sure we did a lot here. This is beautiful. You really can appreciate that at least macroscopically, these chunks of calcium are not fractured. And if you go more proximal, you can, I think, even better appreciate that. Yeah, here also, go. There, at 11 o'clock, you see a big nodule, but the wire is a little bit in front. But also clearly no signs of significant block modification.
Yeah, and
so that's where we are.
What's interesting is that the catheter is lying on the opposite side of where the big thick calcium is, and so it's, even if it orbits, it's going to be very hard to modify the plaque on the opposite side. The point you made though about glide assisting through the bridge, remember glide assist is only 5,000 RPM, and it doesn't actually cause any cutting or ablation. That's really important, because I think you're both bolder than I am. I would have been really worried about taking any atherectomy, honestly, through that bridge and into the distal segment. But if you glide assist through that and then atherectomize the distal segment, that's probably a safer way of doing it. So the question is now, I mean, now that you've done your atherectomy, high speed is probably not going to add a whole lot. So are you going to try NC balloons? Or are you going to try doing some other modification? Yes. What's your thought at this point? Maybe Valeria, what would you do at this point?
Well, that's a surprising result. I think distally we see some modification of the calcium. But then what we want to tackle is the proximal part of the lesion, when we Joost nicely show the presence of a calcific nodule. And probably it's also a kind of a wire bias here, that we see that the orbital didn't really tackle the calcium, the nodule. Can be an option to consider a combined procedure, and in this case, for example, lithotripsy, upgrade to lithotripsy, or also testing also the expansion as they are doing with a non-compliant balloon. We aim for a good expansion of the stents anyhow, and if the nodule is not that much protruding to the vessel, we have a remaining inner lumen sufficient to accept the stents, then we should probably also accept some minor results on the calcific nodule.
Yeah, it looks like that's what they did. And to be honest with you, for me, especially if it's eccentric, most of the expansion of the stent is going to happen on the wall opposite the calcium anyway. So I think that this is a pretty reasonable strategy. Certainly cost effectiveness wise, it's going to be cheaper than doing the lithotripsy, and you don't see something horrendous nodular wise. So I think what Joost did is, Joost, was that a 3.0 balloon, or what size NC balloon was that? And now you're going back and going to show us what that did.
2.5. Yeah,
we'll
okay. Show you what that did on the OCT, 2.5 balloon. Lumen was small.
Well, another option would be a high-pressure Wolverine, right, Ajay? That, could also potentially give you great outcomes. It's not that expensive compared to lithotripsy.
Ja, klaar Martin?
I think.
By the way, there's some question from the audience about the role of cutting and scoring balloons. So I think, as you said, Azeem, this is a good example. This would be a reasonable use. You can also use it to increase the focus force to crack actually more severe calcium. There were also questions about whether IVL works in fibrotic disease. The answer is no.
Okay.
Fibrotic lesions, it actually is not where it should be. And that's one of the reasons why imaging is important. Just because you see a waist doesn't necessarily mean it's calcium. So, all those things are important. And then the other questions about the dual use and combined use, we just need to study it more. We need to understand better what will happen. So let's see this run and go from there. For those that are not familiar with this software, this is the Ultron software. It's pretty intuitive. It co-registers pretty quickly as you're taking the catheter out. It's going to co-register, and then it has calcium detection built in on the AI side, and it's quite nice for those types of purposes.
So we go, so I'll take you from proximal to distal. I think that makes it a little bit easier to orient yourself. So this is the left main. So I think that is already important. Lumen areas of about 9, so that looks beautiful. Then we go a little bit more distal. You see the dot in the longitudinal view. That's the bifurcation with the circumflex at 6 o'clock. And here is the ostium of the LAD, which actually does not look healthy, but also not too bad. So there is plaque. Lumen area is 4. So that's now a critical question. If the distal healthy part would have been 8, I would have perhaps thought, well, let's cover the whole thing up until the ostium of the left main. Here, I have to admit, I'm a little bit in doubt. If you go more distal, you see the calcium lumen area clearly increased now after the balloon. You see also larger dissections as expected on the opposite side of the calcium or on the hinge points of the calcium. Very nice here. You see the chunk of calcium bit back, Martin, at 3 o'clock. And you see the dissection at 5. So that's always at the hinge points of the calcium with the non-calcific plaque. Go further distal. And then the question is what to do. So there's a clear luminal increase already after the balloon. Here it's still small. Again, dissections around the calcium. And then there is no clear, healthy distal reference. So this is...
Looks to me, though, Joost, that, it's eccentric, and it looks to me that your stent would likely expand just as the balloon did, but on the opposite wall. And I just don't know. And even that, that shockwave data with eccentric calcium, there's no control groups. You don't know what would have happened in those cases if you had just used a regular balloon or a Wolverine scoring or whatever. So what are your thoughts? What are you going to do? I'm curious.
So what is the reference vessel size now? What are we talking about? 2.5 or 3.0?
This is definitely...
Why don't we let them think? Margaret, what would you do at this point?
Merely 2.5.
So I didn't
Go distal.
pick up. I would have looked at take 1-to-1 non-compliant. Look at the expansion in multiple views. That's going to tell me
Zo'n
if it's
2,5,
expand in the non-calcified side of the vessel an adequate size. So I would do that.
Okay.
I'm a wee bit
En
concerned
dan tot op
that
het ostium.
really
Zou niet te
thick
gek.
plates of calcium to the more proximal lesion and the one just further down where it looks really, really thick. So I think rather than a protrusive nodule, this has just been a really thick, eccentric plate of calcium in those two locations. And that's possibly why the atherectomy didn't do very much, because the wire bias wasn't against it. And also it wasn't really protruding, like a mass into the lumen. It's more that there's a thick plate on the side. So I think I would take 1-to-1 non-compliant, expand it to high pressure, look at it in multiple views, and then decide whether I think I'm going to get good stent expansion or I'm going to have to use something more advanced. And if I was going to do that, I would go to IVL after that.
So that's great. Joost, what are you doing? Looks like you're doing the same thing.
Here for a stand up until the ostium, and then we will revisit. So distally, we'll likely do some more ballooning or a DCB, but I think here the major interest is in the ostial part. This is a 22538 for post-dilate with a 3.0. 2.5. Yeah, 2.5 test. Yeah.
So whenever you're doing these types of stents, you want to make sure that the stent type can expand to the vessel diameter that you will have of interest proximally, because you can size it distally, but if the stent geometry is not such that it'll expand, then you're going to be left with a stent hanging in the lumen. I think that there was a question that came in before in case this, and we're not going to jinx you because we know this is going to be fine, but in case you were worried that the stent didn't expand, with IVL, you do have the ability to use that obviously off-label to rectify the situation. It's more effective if you do it before the stent than afterwards, but a single layer stent, it can work. That's what the reason I think Margaret suggested what she did with the 1-to-1 size balloon is to make sure you don't have that problem. So I'm curious to see what ends up happening here as this goes up. Now, Azeem, any thoughts? Would you have done something different?
Multiple.
Oh, you go ahead.
I was just going to say there.
You first.
No, I was just saying, obviously, multiple strategies possible here. Obviously, you only know at the end. You can do everything, do a shockwave, do Wolverines, but I have to admit, if the calcium is 180 degrees, these stents usually expand, and the nodule will not go away anyway, so that will always be a luminal comprising entity.
Margaret, what were you saying? Your thoughts?
I was just going to say that there's actually some quite interesting AI work going on just now using IVUS and in some cases CT to predict your wire bias and the effectiveness of different modification devices, which I think going forward is going to be very interesting. So I read a paper recently where they basically every cut of the IVUS they used and put it into a model and were able to predict how the rota would behave as it traveled down the vessel, depending on the wire bias. So I think going forward in our procedural planning, we're going to get more sophisticated with our choices.
Yeah, I think that's why when Joost and Nicolas showed that CT, it was super interesting. And I actually think that the CT, the appearance of the CT makes me feel a little bit better of the strategy. It wasn't this like socked in, tube of calcium all the way down. So let's see. So stent deployed, you post dilated approximately 3.0?
Yeah, correct.
Or bigger?
Nitro.
Okay. All right.
What projection do you want, Joost? Do you want cranial or caudal?
Depends what the interest it is. I think this is a good projection to start. At least we can see the proximal part and then, 1 second. Go. Okay, no. Yeah. Okay.
So it looks pretty good.
This looks very good.
You're going to do an imaging run and show us?
Yeah, we can do imaging, but we basically already know what is the problem, right? So we have this intramyocardial part here in the mid-segment and this tight lesion distal, which is also in a, let's say, in a band with some harmonica effect. So with that, the OCT to me usually doesn't really add a lot. It's also, by the way, what we saw in the previous case of David with his osteal LAD. So I could imagine that we pull the wire and we do a DCB distally, if that looks good. And then we leave it like that instead of stenting the whole thing.
So personally, I think you have a distal edge dissection. That is my guess.
Yeah, exactly.
And then there is that very distal lesion that we agreed upon. We would target that with an essential prodrug-coated balloon, but definitely not stent that. But my guess is that we have a distal stent dissection. So why don't we do the OCT also for time purposes? Then
Yeah, we can.
I think it'll also help you, make sure that proximal stent and the prox LAD, pretty important area for the patient, is well expanded. I think it is, but I think it would help. That distal thing, totally agree with you that a DCB is perfect that way, but you'll get both information at the same time. So while they're putting that in, let's see the poll results. Let's see what folks had to say from the audience, because we want to keep everybody engaged. So why don't you show that real quick? Must have, nice to have. 6% not needed. That's a strong statement. I think you definitely need to have some atherectomy device if you're going to tackle everything.
Okay.
Maybe there's some cases you won't be able to do without atherectomy. But nice to see what the audience said that way.
Right.
So let's show us. Go back to the case and let's see what the imaging run shows.
So we're calibrating.
And so I also know we have Mount Sinai on standby. So we'll leave you with this imaging run. I know you're going to treat the distal and deal with that. But this has been a pretty fascinating case, I have to be honest.
And not so straightforward.
No, but that's why you have to think. It makes interventions fun when you have to think your way through the case and problem solve.
Calcium's never
Are the
straightforward.
cases where there's still an art of medicine. Huh? You have to think, and you have to interpret also the data that is available, and you have to understand all the technology that you have at your disposal.
Yeah, this actually looks beautiful. And this is the remaining issue here. The
That's a distal lesion.
Can we see the distal edge?
That's definitely a lesion.
That's the DCB part.
Yeah, Martin, can you show the distal
Yeah.
edge?
So left, yeah. There you go.
Side branch.
So there's a lesion or
There is a tiny dissection, but
yeah.
I think you can
Looks
get
good.
away with DCBs from your distal edge stent till after the
Yeah.
curve, guys.
Correct.
it's there is some disease, eccentric disease, but
That's not so bad, huh?
no, the stent looks nice. That is all very good. Didn't completely capture the ostium, which is a pity, but okay. Yeah. So lumen area distally,
expansion looks good.
Martin, just distal to the stent. Yeah, so that is good. So this. So there is some disease here between 12 and 4 o'clock. Lumen area is very small.
So a question to Azeem. Azeem,
It's all,
would
but I'll be
you
honest,
like
that
to cover this all with a drug-coated balloon?
No, I actually now when you show me that small area, I would put a short stent distally at the edge to get a better stent, get a
Yes.
better MSA there, and then from there drug coated balloon, like just a 12, not very long, just at the
I
distal
agree.
edge, and then drug coated balloon further on. I didn't when you stopped and Martin stopped on that picture there where there's really a bad lumen. I don't think you're gonna get a great result just with drug coated balloon.
And the MSC is
My
less-
concern
Now we gotta
is if
run
you
to
go to 50. You also see an MLA of 1.6, so it's
Okay, we'll do some digging.
Yeah.
We'll do some digesting here, but because Mount Sinai is also waiting, I assume.
yeah.
Yeah.
Yeah, no, you guys, maybe we can come back to you. Hopefully we will, but if not, thanks. This is great. Honestly, great demonstration with everything. And let's now move on to Mount Sinai, and we have Amit, Hooda, and Kini. Let's show them. It's really great to see them. They're not very far away from me, but it'll be cool to see what they have to present to us.
We will never see them. Good afternoon. Can you see us?
We're excited. We can, and we're excited to see what you have to show us.
Okay. Thank you, TIO, for inviting us again this year also. And thank you, Ajay and the team. I saw an excellent panelist. So we're going to show you the case. If you can bring the slides for the patient. So myself, Dr. Kini, the director of the cath lab, and I have Amit Hooda. He is the associate director for the fellowship program, who is going to help me. Frank and Gaurav. We have a big intervention fellowship program. So we have fellows who help us, and of course our cath lab team. So if we can show the first slide of, yes, that's where we are. We have a No disclosures. So this is the case for the session 2.4, 75-year-old male patient. Clinical presentation was dyspnea and a positive CTA for had a calcium score of 466. Of course, showed left main LAD and RCA disease. Now, this was done as a preparation for patient going for a stem cell transplantation as a part of multiple myeloma. So we are a big cancer center, and they all see a cardiologist, cardio-oncologist. Risk factor-wise, hyperlipidemia, COPD. So SAQ of 87, BMI okay 27. So if you take his other lab parameters, no diabetes, but they always check it, 5.6. Now LDL is 48. CRP is slightly high, could be two reasons. One, not on statin. Two, could be that he's multiple myeloma also, and has been on chemotherapy waiting for the transplant. So the echo had shown that EF is low, but our LV gram showed that EF is okay. So if you see medication, good medical therapy, but for the CAD wise, he is not on beta blocker because of COPD, cannot take statins, and he's on PCSK9 inhibitors. So cath was done late March, which had shown that he had left main disease, LAD disease, and RCA was totally occluded. Since need for transplant and DAPT probably will be interrupted very early, the primary doctor cardiologist felt maybe get a heart team discussion, and then we can decide. And of course, because of the comorbidity, CTS, and the patient declined. So today he's here for PCI. So if we can go back to angiogram. So EDP was good. He had hydration for a few hours. EDP was 8. Creatinine is 1 today. So you see the EF is good. We didn't do our RCA picture, totally occluded. So this is where we are. You see that moderate left main disease, but more important is it is a trifurcation. So if we go with other criteria where if you just see it on the V gram, you can see speckles, maybe moderate calcium, not severe calcium that we can classify on angiography, not ramp track. So you can see that calcium even here. So moderate left main disease and a significant ostial LAD, which you can see in cranial view. So in the caudal view, you have a large ramus, and there is this large circumflex, probably okay. So this is where we are. You can see that ostium of the LAD is involved. Of course, then we had done the IVUS, so we can quickly show the IVUS run. Kiski?
Yep. Can you show the IVUS on the screen?
And Anu, one quick thing with the stem cell transplant impending in the near future, you're probably going to try to make this as simple as possible, because the DAPT is a real issue, because the stem cell be done, the patient's going to get pancytopenic. So you're going to try to make this as simple a stent approach as you can, right? Is that what I'm in surmising?
Yeah, that is the plan. Yes, that is the plan. But of course, I think we thought we will image and see if ramus, based on the angiogram, I think ostium looked okay to me, but we have done the imaging, which you can see.
So we use the
Sorry to interrupt.
Amigo Plus. Yeah. AI integrated high definition IVUS. This is from mid LAD to this is ostial LAD, left main, and go to the guide. So I focus on the calcified part. So this is a proximal LAD. You see the 9 to 10 o'clock, there's a protruding calcified nodule. The surface is smooth, so we can call it a non-eruptive calcified nodule. When we go back to the ostial LAD, it's very focal, but you see the 270 calcium arc. And go back to the left main. That's this before the circ. This is a distal left main. And the area-wise is 4.5 based on the IVUS, and with a 270 calcium. So distal left main is definitely tight. And calcium score, we have a 270 calcium and a calcium nodule. So IVUS score is 2. So we think we need additional atherectomy devices.
So essentially what we are saying is, the arc of calcium, we are getting three quadrants, and then we have a calcium nodule, though we don't think the length is not more than 5 millimeters, but either way, IVUS criteria greater than 2, so make it severe. I did hear the discussion of your previous case. In this kind of situation, what should be one, the question would be the same. Should any kind of atherectomy device be used? I think we all feel atherectomy device should be used for proper lesion preparation and stent optimization. What should be the device that we should be using? We felt that since it is a short lesion, that IVL should be okay, just IVL. But if anyone feels different, then we are ready to do rotational atherectomy also. But if you go back to the IVUS analysis, you see that the lumen, the diameter there is already 1.6. So 1.7 burr barely may do anything. If you need something, we will need like a 2 burr from left main to LAD. Yeah. So other than that, can we just do IVL? Yeah. So I want to know what you guys think.
Yeah, I'd be curious. For me, I totally agree with your assessment. Maybe orbital will get it, but I don't think you need to do it. Honestly, there's some people who would say do cutting balloon in this situation to see, whether that alone modifies it. But Azeem, what are your thoughts? I think we need more study of this. Azeem?
Yeah, absolutely. I mean, I think a short lesion, you're trying to keep it simple. If you look at some of the areas, the residual lumen is actually quite large. So if you were to go with rotational atherectomy, you need quite a large burr. I like the idea of using IVL here. I would either in my practice, it would be IVL versus high pressure Wolverine. Those would be the two options we'd probably try.
Yeah. And Anu, you keep working. Valeria, what are your thoughts?
Yeah. So what we decided is we'll take the IVL. Since we image the ramus, I have left the wire in the ramus anyway, which we can leave if you're doing IVL. So we took a 3.5 just because if you go to the LAD, right, we are going to use the same IVL balloon both to the left main and LAD. So we took a 3.5, all the left main. I think we are getting like a 4.5 diameter. So we will go. Yeah. So you see that? Yes. So other thing is, remember, RCA is total and VA is the left main IVL. So we got to be very fast. Yeah, go.
Yep. Go ahead.
In the osteo-limas area is 5.0. So it's not obstructive based on the initial IVUS of the limas.
6, I think.
I have to say that the use of cutting in this case, actually the effectiveness of the vulva and how a cutting balloon on a calcific nodule is not really well demonstrated in literature. So I think the data we have with the IVL are more robust, and we also take advantage of the fact that we can leave a second wire. It's a bifurcation, so that's also nice as compared to atherectomy device. So I think it's a nice choice.
Yep. Margaret, your thoughts?
Can you show the hemos by the side?
I think the nodule is pretty small and it's not that protrusive, and it's localized about 90 degrees of the vessel. There's not much associated concentric calcium. The 270 calcium in distal left main is over a very short length. So I think IVL is a reasonable choice, but I think you also might just delete all this effectively with a big non-compliant balloon. Because the calcified segments are focal. So that would also be an option.
Looks like
I was worried about that in the left main. But you could do an NC balloon via IVUS and then use IVL as your second choice. It would be my strategy.
Anu, it looks like the hemodynamics are okay. Sorry to talk over you, Mark. Anu, it looks like the hemodynamics are okay. Or am I seeing that right? I mean, I just want to clarify that for the audience.
Yeah, it's okay. But you see that I have the guide outside. Okay.
Yeah.
Yeah, good.
So super important. Guide is disengaged.
Great.
And remember, the balloon's 3.5, so it's not going to obstruct the left main because it's 3.5. So you're still probably having some flow down the circ, maybe some flow down the ramus. If you wanted to test to figure that out, you could just do a little injection and see and make sure that's the case. And especially in the occluded right, that's important. I remember when IVL came out first, there were a lot of people saying, oh, if I use IVL on the left main, I'm going to need to put an impella in and things like that. And I would say in most cases, you don't need to do that. And there's not really that many issues, even if you're inflating in the left main itself.
I want to take a picture.
Just deflate
but yeah, sorry to interrupt. Yeah, that is just deflated at that point.
So Ajay, I mean, you guys are doing a randomized study comparing IVL and cutting balloon, right? What kind of lesions and how far enrolled is that study?
So I just got an update today, and we were actually, there's two cohorts of patients. One is non-atherectomy patients, one is atherectomy. The non-atherectomy cohort, which is cutting balloon versus IVL, is fully enrolled. Honestly, this case would have qualified. So I think it would have been a great case to study that in. The atherectomy cohort is after you do ROTA, you then randomize to IVL versus cutting balloon. And the imaging endpoint is the one that's being assessed. And we hope to be able to present that at TCT. So we're almost done, which is pretty cool.
Show the IVUS.
We'll have some randomized data.
Yeah, I'm looking forward to see that, especially since I seem to be the only one out of the three of us who likes cutting.
IVL.
Oh no, I
dissection.
No, actually, in my practice, I'm a real convert back to them. See, because the trial, actually, I've really converted back to using them much more than I was before the trial, which has been interesting.
Yeah, huge dissection, opposite to the calcium perk.
Yeah. Angiographically also we could see maybe a little bit, I would say, contained microperforation in the LAD. So let me go back. If you see that, you see that?
You can show the angio.
Can you appreciate that? In the proximal ostial LAD, yeah. And you see that in the IVUS you're saying?
Yeah.
Yeah.
So it's in the opposite part where the normal looking vessel, yeah.
Yeah.
I mean, we went 3.5 and barely like 4 atmospheres. Okay.
I mean, you can get,
it's not
get
flow
these
pocket
things,
to
I
the
think,
distal.
yeah. It's rare, but there are cases with...
So I think Ramus looks good, right?
Yep.
Yeah, Ramus looks good. If everybody agrees, do we just go ahead and stent it now? It's fully expanded based on the, right? We don't need to dilate again?
I think so. The area-wise is much bigger. Of course, this IVUS resolution, we cannot see the fracture in the nodule, but lumen-wise, it's much bigger than the previous.
Okay.
And a lot of dissection. It's a good plaque modification.
So we'll go with the 3.5/28 and then we'll post dilate into the left main. Anything else you think, any different way?
No, I think... I think it's great. The one thing I would just comment on is that the use of the score to determine when to use advanced modification. I mean, for us, it's really the 4s that are the ones where we're using advanced modification. At 2 and even 3, we will tend to try NC balloons or other things like that, especially that length issue, because for me the length is really the most important thing. Honestly, if you have a short focal 360, that will often crack. So I don't think there's anything wrong with doing it this way. It's a very efficient way to do the case, but this is, I think, why we need more detailed data and analysis, because I think many times these types of cases, it would have worked with either NC or scoring or cutting, but this is reasonable too. So I'm curious to see, it's going to look good after stenting, and then we can maybe talk about the whole DAP situation too afterwards. So you're going to size to the distal vessel. For the audience, remember, size to the distal vessel.
I'm going to see,
make sure you take a stent platform that can expand enough for the left main.
So that, Ajay, that appearance that we got with the extensive dissection, I think you more often see that when you've got a combined fibrocalcific lesion, because as you mentioned earlier, IVL is actually hazardous in fibrosis. In isolated fibrosis, it can cause extensive dissection. I've seen that in a case before where somebody used it without thinking it was calcium, and it was all.
We have a 4-5.
We have 4-5.
I think here probably a combination of calcium and fibrotic disease, and that's why you saw that, I think.
That makes good sense.
4-5.
Now, this calcific nodule, again, I mean, we actually published, we presented in ESC, and, we have published about how to take care of nodules, because one sticking factor in the calcium is always when we are seeing a nodule. So this nodule was less than 90 degree and superficial calcium, so we knew would respond well. But otherwise, if you have severe calcium, 360 degree of a calcium plate around it, and we have been through that cases that you will never see, not able to deliver anything, and then we are trying to expand later, that becomes an issue. But I also heard Ajay, you mentioning that if we use you do some kind of atherectomy, you did cutting balloon, high pressure balloon, place a stent, and you still think that we are not able to get a good MSA, we do have, like you mentioned earlier, that we do have the IVL, which we have done in freshly placed stent. So I'm going to remove this side branch wire now before we do optimization. This is a 458.
Yeah. Left main is 4-5 vessel.
Yeah, okay, good. Okay, go here. Can you see it?
So this
Here,
pod
right
is
spot.
super important because it makes you really oppose nicely in the left main. It'll actually open up, hopefully, the struts towards those side branches too. So
Yeah, down.
the step is a really important step.
Andrew, can you show the video for the provisional stenting? Go. So we do have our
6-8.
app that we are going to show you by the side.
Go ahead.
So that's ostial LED. We dilated again. We're going up again here. Go. Yeah, that's it.
Just
not
going to
too
expand on what Dr. Kini was saying about
And we
that.
get the IVUS ready.
There's some messaging going around that atherectomy doesn't reduce volume of nodules in coronary arteries, and it isn't true. There's now some data that shows that if you've got a truly protrusive nodule, you can reduce the protrusion by almost 30% with atherectomy. So the kind of messaging going around that you don't need to reduce the protrusive volume of a nodule, a significant nodule in a lumina, I think should be countered with that data.
Yeah, no, good point. So this is the Bifurcate app, right, Anu?
Yes. So this is animation 3D. We just did provisional. You can show if we have to do, Andrew, the next bailout, if you need bailout.
Are you gonna rewire the two side branches and dilate those struts, or just leave it like this where it looks pretty good?
I think I'm not a fan of rewiring and doing dilation. So we are the ones that are actually published based on the Excel data that once you did the left main stent, actually if you did
Now we do
single stent strategy and did kissing balloon, the outcomes, especially slightly, not statistically significant, but slightly increased stent thrombosis. But they were old stents. And, during the Excel time, the technique was not well defined.
It already.
Some of it, though, may also just be confounded by the fact that those patients in whom you have to go back and kiss are probably sicker in some way or another. I mean, Excel was EES, and the use of IVUS was in at least 3/4 of the patients. So it's pretty reasonable, but I think your point's well taken. I personally would not go back and wire the circa, the ramus, and dilate them. I think if the expansion looks good, which it does.
Let's ask the panel.
I think you're okay. Yeah, anybody
also think
raise
in
your hand
this
if you want to go
patient,
back and
I think also in this patient,
Or you can ask a question, right? Paul.
Yeah, thrombocytopenic in the future with the bone marrow transplant and so on. Having one large stent that's not deformed makes me feel the most comfortable. I like this strategy.
Valeria, would you rewire and dilate? The Europeans are very, very meticulous and prescriptive about this. So tell us, no?
That's true. That's true. But despite that, even the EBC recommendations, there's no evidence that routine systematic kissing balloon after crossover stenting actually leads to a better result. So I think in this case, angiographically, both side branches look very good. So there's no reason to proceed with kissing balloon.
Agreed. So I know we've got to go back to
You
Nicolas.
want to go over the IVUS?
What are you going to do with the DAPT?
Yeah.
It looks good to me. Yeah, you can go over it real quick. Go over it real quick.
Yeah, go over anything we need to be worried about, Kiski.
No, it's an area where it's very great. Distal left main area wise 12, and a causal nodule part is eccentric shape at area wise 7.0, and the distal edge cover the dissection, normal opposition. Proximal edge is at the ostial left main. So IVUS, it's perfect.
Perfect. Okay, so beautiful. He says he's happy.
Plus longitude.
We have to make sure our IVUS colleagues are happy. Yeah,
That's right.
So going back to the
So what
TAPT will be PRU. Yeah, so what happened is, remember he saw the surgeon, and then when we decided he's coming back for PCI, the primary cardiologist did talk to me, and we put him on Plavix. Do you have his platelets? Oh, platelets are 471. We don't have to worry. And PRU is 64 in a week of Plavix therapy. So if everything good, since we did IVAS, I think we'll be comfortable, though it is left main, right? For stable now it is 6 months, but since we have IVAS guided PCI, we should be okay to stop in 3 months.
Yep. And then when will you let him go?
What
for
do
the
people feel?
The stem cell transplant. No, I agree with you completely. But the transplant, will you let him do it at 2 months, 3 months? When is that going to happen?
So that's another thing. So if first thing we need to ask, do they need interruption or complete stoppage? I think so we'll be comfortable at 3 months. End of 3 months, I will let the patient have clear for transplant.
This is a great demonstration. We're going to leave you and jump back to Nicolas so he can show the final result. But it was a lot to cover. You did it as a pro, as you always are, with your whole team. And thank you so much for really enlightening us on this case.
I just need to show. Can you show the first final slide? Because a lot of people online. So we have that our app. So cardiologyapps.com slide. So people for the younger generation fellows who are online, they should be able to put that slide on.
Can you switch to their slide?
Yeah.
Switch to their slide. There you go.
Yeah. So if they go to, cardiologyapps.com, so we have 14 educational apps. They are free to be downloaded, both on Apple and Google Play. Everything is there. So next one we are doing will be the hemodynamics one.
Yeah,
Thank you for inviting us.
Free. It's genuinely free, so it's good. So it's all good. Thanks, Anna. Why don't we, go to Nicolas? Actually, let's do this. Let's open a poll question and then we'll go to Nicolas. So you saw what she did. That's great. But what would have been your choice of calcium modification for this type of case? So that A is cutting balloon non-compliant, B is rota, C is orbital, D is IVL, and then E is OPN or super high pressure. So I'm curious to see what, they did a phenomenal job, but curious to see what people would have done. And we actually see it here. The most would have used IVL or a super high pressure balloon. So interesting results. Let's kick it back to Nicolas and Joost for the final, and we'll close out at that point. Hey, both. Sorry, I know you've been waiting for a while. What did you end up doing?
No problem.
Not that long. So what did we end up doing? So we discussed a little bit and then put in a very small 225/9 stand at the distal edge where it really looked ugly. And this is the final result. So after a 225/9 and a 2025 Essential Pro DCB distally, exactly in that hinge point distally in the distal LED. We did make a final OCT run, which Martin will show you now. So here you can see or appreciate that distally it looks okay. Then we go into the segment of bridging here, where the lumen area really decreases to 1.4, and then more proximal, you see that now this new 225/9 stand ends in a completely distal, healthy reference area. So if you go a bit more, so that looks beautiful. No dissections anymore. Again, lumen area again still only 2.6, but at least no signs of trauma. A bit more proximal, you see that the minimal stand area is about 3.6. So that we post-dilated a bit more aggressively with a trio balloon to 20 atmospheres. And then also proximally, you see that we cover the ostium with a stand that is slightly protruding into the trifurcation. But with this, we were actually very happy.
Yeah, I think you covered what we wanted to cover. And we also delivered some paclitaxel anti-proliferative therapy in the distal segment, and we stayed away from the bridging segment. So yes. I'm very pleased with this hybrid therapy result.
Yes, absolutely.
No, this is great. I think it's a great demonstration, and clearly the data is going to be forthcoming in terms of whether this works long term or not. And that's why, coronary is still always fun. I know, Nicolas, you're a structural guy, but you still like coronaries, which is what I like about you. So it's all good. Thank you both for that. And I just want to say also, what a way to close out the day. It brings us to kind of the end of day 2. Don't forget to request your CME so you get credit for having watched. And big thank you to Azeem, Margaret, Valeria, also Holger too. It was great hearing your perspectives and from a lot of different backgrounds as well. And special shout out to the case operators. So Nicolas, Joost, your whole team, Anu, Amit, your whole team as well. Brilliant work all around. And we'll play a short closing video and then close out the day.